a very good morning. On behalf, I'm so used to saying behalf of the Institute of Diabetes. Okay. So first of all, I would like to thank the scientific committee and especially G Vijayakumar sir for again giving me one more opportunity. And next, I would also like to thank my director of diabetology, Professor Dharmarajan, for helping me with the slides. And like sir said, painful neuropathy, a good number of patients come with this complaint. And Ravindranath sir has set the stage, so half the work is over. So this is how my talk will go on in the next few minutes. So diabetic neuropathy, it is the most common and most perplexing complication of diabetes. And this neuropathy, it affects around 30 to 100% of the patients. So depending on various studies, this is the census which has come. And almost 60 to 25% of diabetes patients, they experience some form of chronic pain, which may be referred as diabetic neuropathic pain or diabetic peripheral neuropathy. Now, when we talk of painful neuropathy, we should be able to define what is pain. So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage described in terms of such damage. So this was a definition by the International Association of Study of Pain. And neuropathic pain is the pain initiated or caused by primary lesion or dysfunction in the nervous system. So diabetic neuropathy can be classified as polyneuropathy and mononeuropathy. And polyneuropathy is sensory, motor, autonomic, proximal and truncal, and mononeuropathies are usually cranial truncal, isolated peripheral and mononeuritis multiplex. Coming to the common types of diabetic neuropathy which are associated with pain, when we talk of focal and multifocal painful neuropathy, the cranial neuropathy classically is painful in diabetes patients. Then the focal limb, for example, the entrapment neuropathy is associated with pain. Then diabetic amyotrophy. So this is a very important, much less commoner than the other forms of neuropathy. So this is associated pain, and it is mostly starts as a unilateral problem, and with time it goes into a bilateral problem where there is proximal muscle weakness. So this diabetic amyotrophy is associated with pain, and then the truncal radiculoneuropathic pain is the classical painful neuropathy, the girdle pain. Then the generalized symmetrical painful neuropathy, the acute sensory neuropathy, it is always painful when with hyperglycemia. Then chronic sensory motor neuropathy, this is the most common type we come across in our day-to-day practice. Then chronic predominantly sensory, then diabetic lumbosacral radiculopolyneuropathy, and neuropathy with impaired glucose tolerance. So with IGT also, patients may develop neuropathy. So this part sir has already talked, but this is in fact a paradox, because the development of pain in the area where the patient actually experienced sensory deficit due to nerve injury. So this becomes a painless, painful leg. The underlying mechanism driving this is a neuronal hyperexcitability which arises in the primary afferent fibers and spreads more centrally. And this part sir had already explained in detail. This is very important. So blood glucose levels, high excursions of glucose were seen in patients with diabetes who had painful neuropathy, whereas blood glucose was much more stable than those in those with painless neuropathy. I hope you understand. So wherever the patients had fluctuations in blood glucose, so there the neuropathy, painful neuropathy is common. When the fluctuations are not there, either be a good glycemic control throughout or a little hyperglycemia but not fluctuating too much. So both are associated with painless neuropathy. So this is how I would like to explain. So the continuous hyperglycemia is not associated with painful neuropathy, whereas the oscillatory hyperglycemia is associated with painful neuropathy. Sir already said in the previous presentation, there is release of inflammatory cytokines which cause vascular complications like diabetic polyneuropathy, painful neuropathy. So what are the signs and symptoms? The positive symptoms and negative symptoms of neuropathy. So positive symptoms are a persistent distal burning or dull pain. So patients usually will come with complaints of vague deep pain, and there will be persistent proximal aching pain in the legs, more common with the amyotrophy. Proximal electric shooting stabbing pain, this is very common symptom. Kaal ilik ridmari valikide, and usually these pain increases or exaggerated during the night time, which gives them sleepless nights. Dysesthesias and evoked pains are common. Negative signs can be hypoalgesia, analgesia, hypoesthesia, anesthesia, decrease in thermal vibration and pressure sensation, and abolition of reflexes. Coming to the diagnosis and assessment, it is necessary to distinguish between criteria for the presence of neuropathy and criteria for painful neuropathy. So, if your patient is having only neuropathy or if there is pain associated. So, there are a lot of screening tools. Michigan Neuropathy Screening Instrument is one such. Then we have the neuropathic pain questionnaire, neuropathic pain symptom inventory, everything you can get in the Google search. You can go through these and you can utilize them in your practice. Coming to the management, now this is important, the management of painful neuropathy. It includes a good glycemic control with the help of lifestyle modification. Patient education goes a very long way in managing painful neuropathy, and then of course we have the pharmacological and non-pharmacological treatment. So patient education plays a major role. Other than that, we also have to address the other risk factors for macrovascular disease like hypertension, obesity and smoking, and we should also look for the comorbid conditions like depression, anxiety and insomnia, which will exaggerate the painful neuropathy, and the understanding of patient may be little less if the insight is poor. Now patient education goes a long way. They have to understand about the pain mechanisms which can help to allay the fears about undiagnosed disease or amputation. So most common fear is when you tell that they are having they have loss of pain, loss of sensation and there is pain. So they feel there is some infection, some problem inside and they may need amputation. So this fear has to be removed. Then they should also be informed about the benefits, limitations of the treatment and adverse effects of the treatment, and they should be made aware that the treatment is likely to achieve less than complete pain relief. So it is not possible to give complete pain relief, but at least it may be reduced, it may not go completely, and they should have a realistic expectation. So they should not expect that if you write a medication, the next minute pain is gone, right? So like when there is fever, you give paracetamol, the fever comes down, but that doesn't happen with painful neuropathy. That they should understand. It may reduce and the effect may not be immediate. It may take a week, 2 to 3 weeks for the effect. So about lifestyle intervention, there was in DPP, they saw that treatment with diet and exercise for a year in patients with IGT, it produced a significant increase in intraepidermal nerve fiber density in the proximal thigh, and this helped in reducing the neuropathic pain. So coming to pharmacological treatment, there can be general and specific treatment. General treatment includes strict glycemic control, and this is usually done with insulin because insulin has a membrane stabilizing effect which will help in reducing the neuropathic pain. So when patients come with acute painful neuropathy or severe painful neuropathy, you can always advise them insulin for a short period of time. Once the pain reduces, you can slowly de-escalate the insulin. Then next is the treating the metabolic abnormalities. So among these different drugs, what we have now is the epalristat. Sir talked about the polyol pathway. So these drugs act on the aldose, these are aldose reductase inhibitors. Then the other treatment includes EPO, evening primrose oil, which is rich in GLA, which is an antioxidant. Then ALA, neurotrophins, PKC inhibitors which are not available, AG inhibitors not available, gangliosides, myoinositol is not very useful, but these are the common drugs which are available. Then we have the specific pharmacological treatment. The most commonly written drugs are antidepressants, anticonvulsants and opioids. So among the antidepressants, tricyclic antidepressants like amitriptyline, imipramine, nortriptyline and clomipramine, and SSRIs, SNRIs, duloxetine and venlafaxine. And then we use gabapentin, pregabalin most commonly, and opioids like morphine, oxycodone, tramadol can be used. Tramadol is commonly used for pain which is not responding, and when you need immediate effect, when they want quick relief of pain, tramadol is helpful. So irrespective, this is the most important part of today's presentation. If you take it back and you are able to educate your patients, it will give a good bonding with your patients and they'll come back to you again and again. So irrespective of which treatment protocol is offered, fewer than 1/3 of the patients will achieve 50% or more pain relief. So pain relief will not be, it may reduce, but it will not go fully. And many a times when they come for review and you ask if the pain is still there, they'll say, yeah, it is lesser. So please don't reduce the medication, right? So you continue. Only if there are very severe adverse effects, in that case you can stop the medication, but otherwise you can continue it for a longer period of time. So antidepressants, RCTs, meta-analysis have demonstrated the benefit of TCAs, especially amitriptyline or triptyline in painful neuropathy, and onset of analgesia is variable. Improvement in insomnia, anxiety and depression is the plus point with this class of drug. Desipramine and non-triptyline have fewer adverse effects, and TCAs are contraindicated indicated in patients with cardiac decompensation, cardiac autonomic neuropathy and epilepsy or glaucoma. And the commonest side effect is drowsiness, and they may come back with complaints of giddiness, dry mouth. So these things we should remember when we are treating the patients. Now what about anticonvulsants? So commonly we use gabapentin and pregabalin, and of course carbamazepine. You may use phenytoin, lamotrigine, chlorpromazine, benzodiazepines, clonazepam, sodium valproate. These are the other drugs which can be tried. And anticonvulsants, they act via two main mechanisms. Either they block the sodium channels or they bind to the calcium channels. Like Sir said, these are the channels which are affected. That's why you can use multiple drugs together. And these effects, they will reduce the peripheral excitability because you are now attacking the channels. Pregabalin, it is a structural analog of GABA, only FDA approved drug for painful neuropathy. It is a long acting drug. You can start with a small dose of 75 or even 50, and you can increase up to 200 milligram 3 times a day. It may act by modulating neurotransmission in presynaptic dorsal horn neurons, and it is also useful for post-herpetic neuralgia and epilepsy. Other therapies, opioids, dopamine agonists like fluphenazine, antiarrhythmics like lignocaine, and normal saline infusion. This has been shown to be useful in painful neuropathy, especially associated with diabetic amyotrophy. And then topical therapy, capsaicin, which is a chili pepper extract, topical application of 0.075%. You can also use transdermal lignocaine or topical amitriptyline. So all these things are available. And when you compare the relative efficacy of treatment, the relative efficacy of different treatment investigated for neuropathic pain showed that TCAs are the most effective agents, and duloxetine, gabapentin, pregabalin, these are also equally good. So which drug to use for which problem? So when the patients come with paresthesias, dysesthesias, right? So the tingling and all these, so there the tricyclic antidepressants are very useful. When there is a lancinating pain, then you can use fluphenazine. For superficial burning pain, superficial, so topical application. Pain of mononeuropathies, gabapentin, pregabalin. Focal neuropathies, carbamazepine. So this is just a rough idea, and it may not be that this is exactly what it is. Different patients may respond to different modes of therapy. So this is the algorithm for painful neuropathy. Depending on the contraindications and comorbidities, you can choose any of these 3 drugs. The pregabalin, gabapentin or TC or SNRIs. If still it is inadequately controlled, you can add. Still it is not controlled, you can use opioid analgesic. You can refer to a neurologist. So non-pharmacological treatment is neuronal blockade, neurolytic techniques and stimulatory. So among this we use TNS, PEMF. So PEMF now is advocated by the ADA also as a treatment modality. Now when will you refer? So when the patient is very nagging, you are not happy with the patient and you are not happy with your neurologist, you can refer. Another thing is pain refractory in spite of medical therapy, gross motor involvement in addition to sensory symptoms, patient not tolerating drugs, and when the patient complains of sleep disturbances or poor quality of life in spite of adequate medical treatment. So these are some of the indications when you should refer the patient to the neurologist. So what is the conclusion finally? So it is painful neuropathy, it's a disease, it's not just a symptom, and treatment goal first and foremost is patient education, lifestyle intervention, glycemic control, and then the pharmacological and non-pharmacological treatment, and it is not in this order, everything goes together. Rational polypharmacy is often necessary. One single drug may not be helpful, so combining peripheral and central nervous system agents will enhance the pain relief. Irrespective of treatment, less than 1/3 of the patient achieve 50% or more of pain relief. Management poses a challenge to clinicians. A broad, holistic approach to management is considered essential. Patients often feel misunderstood because there is no obvious signs of pain, and listening to and supporting the patients, particularly those with severe pain itself, can be therapeutic. Thank you everyone for the patient listening.
So the take home